We'll move now to colonic polyps and then to colorectal cancer. The simple definition of a polyp is a mass that protrudes into the gut lumen. They often have a sawtooth appearance on histology. 90% of polyps are actually non-neoplastic, but when found on colonoscopy are removed or biopsied just to be certain. They're more common in the rectosigmoid area. Now, because colon cancer is an adenocarcinoma, the polyps that are precancerous are the adenomatous polyps. There's a greater risk of malignancy in a larger polyp, one with villous histology, and one with increased epithelial dysplasia. A mnemonic you can use is that the more villous the polyp, the more villainous it is because of its chance to cause cancer. There are three special forms we like to mention. The hyperplastic polyp is the most common non-neoplastic polyp, with over 50% found in the rectosigmoid colon. Juvenile polyps are sporadic lesions in children under age 5, and fully 80% are found in the rectum. If there's just one, it's not malignant. On the other hand, when multiple are found and juvenile polyposis syndrome is diagnosed, there's an increased risk of adenocarcinoma. The Peutz-Jeghers syndrome is an autosomal dominant disease with multiple non-malignant hamartomas throughout the GI tract. Patients often have hyperpigmented mouth, lips, and genitalia, as well as hands. This genetic disorder has a high risk of colorectal cancer and other visceral malignancies, such as pancreatic and breast cancer. Colorectal cancer is a massive topic of great public health relevance. We'll try to hit some of the high-yield points here. Colorectal cancer, or CRC, is the third most common cancer in the U.S. and also the third most deadly. Most patients are over 50, and about 1 in 4 have a positive family history. There are various genetic syndromes that give a predisposition to CRC. Familial adenomatous polyposis, or FAP, is an autosomal dominant mutation of the APC gene on chromosome 5q, where colon cancer is assured. Patients literally have thousands of polyps throughout the colon, usually including the rectum. The two-hit hypothesis, in its simplest form, is that one mutated allele is inherited, and sometimes during life, the other allele is either deleted or mutated, leaving no functional gene. Gardner's syndrome is when patients have FAP, and also osseous or soft tissue tumors, as well as retinal hyperplasia. Charcot's syndrome includes FAP, as well as malignant brain tumors. The genetic cause you may be most familiar with is HNPCC, or hereditary non-polyposis colorectal cancer, also known as Lynch syndrome. This fact is often looked over because the acronym is so catchy, but remember that the name specifically says hereditary non-polyposis, meaning there are no precancerous polyps. Instead, small adenomas in the colon, which are easily overlooked on colonoscopy, can harbor advanced cancers that would eventually only manifest in large polyps. Lynch syndrome is autosomal dominant and involves mutations in DNA mismatch repair genes. What other major type of cancer can have a genetic link to a gene that codes for a DNA repair enzyme? That's right, breast cancer, which appears more often in patients that have a mutation in the BRCA1 or 2 gene. Around 80% progress to CRC, and patients with Lynch syndrome are at high risk for many other types of tumors. The proximal colon is always involved. We went over some of the risk factors already. IBD, villous adenomas, juvenile polyposis, and Peutz-Jeghers syndrome. Some other risk factors are strep bovis infection, as well as tobacco use. The strep bovis connection is so important that if you see a question that includes the words strep bovis, look for an answer choice about colorectal cancer or colonoscopy for CRC screening. This is a particularly important fact. The presentation of left-sided versus right-sided colon cancers. Remember that the left side, or the descending side, obstructs, while the right or ascending side bleeds, which can lead to iron deficiency. Or more specifically, cancers in the distal colon cause obstruction, colicky pain, and hematochezia, whereas cancers in the proximal colon cause dull pain, iron deficiency anemia, and fatigue. Regarding diagnosis, the classic teaching is that iron deficiency anemia in older males is colorectal cancer until proven otherwise. Let me say that again because it's super important. The classic teaching is that iron deficiency anemia in older males is colorectal cancer until proven otherwise. Patients over 50 should get a fecal occult blood test and a colonoscopy. A barium enema in advanced cases might show an apple core lesion. CEA is a tumor marker that's positive in many cases, although not useful for screening. Clinicians still often get serial measurements to follow response to treatment, however, though this has not been shown to be completely accurate. Regarding the molecular pathogenesis of these cancers, there are basically two different pathways. Microsatellite instability, which accounts for only about 15% of cases, while chromosomal instability, specifically through APC and beta-catenin, is implicated in the majority. The microsatellite instability pathway is when DNA mismatch repair genes are mutated, either sporadically or in the Lynch syndrome. Chromosomal pathway involves mutations of APC and beta-catenin, as mentioned previously. The diagram shows the standard molecular progression. We start with a normal colon, and when the APC gene is mutated, the colon is now at risk. Loss of APC leads to decreased intercellular adhesion and increased proliferation. Then, if there is a mutation in the KRAS gene, intracellular signal transduction becomes unregulated. This is the point where adenomas form and can be discovered by screening. After APC and KRAS are mutated, the last step is loss of p53. At this point, there's increased tumorigenesis and formation of true carcinoma. Do you remember what type of hereditary disease involves deletion of p53? I'll give you a hint. It leads to development of many different types of cancer at an early age. That's right, Li-Fraumeni syndrome. Okay, we finished colorectal cancer, so now we'll talk about the carcinoid tumor and carcinoid syndrome. This is a rare tumor, but interesting and thus commonly tested on step 1. It's actually a neuroendocrine tumor and constitutes fully 50% of small bowel tumors. As you know, colorectal cancer is generally in the large intestine, not the small intestine, whereas colon cancer is the third most common tumor. Small intestinal tumors are quite rare. The most common sites for carcinoid are in the appendix, the ileum, and also, though not in the small intestine, the rectum. And they're most commonly malignant when found in the small intestine. EM histology shows dense core bodies, which is a buzzword that you should know. Carcinoid tumors that produce 5-HT, or serotonin, cause the carcinoid syndrome. Classic symptoms of carcinoid syndrome include wheezing, diarrhea and flushing, as well as right-sided heart murmurs. Basically any kind of symptoms that an overproduction of serotonin would produce. The important thing to recognize is that if the tumor is confined to the GI system, these symptoms don't occur because the symptoms are caused by serotonin, which can be easily broken down by the liver before distributing to the rest of the body to cause the symptoms. However, if the tumor is metastatic to liver or beyond, and the liver's ability to break down serotonin is compromised, then symptoms can appear. So that's pretty important, so let's take a step back and repeat that one more time. If the tumor is confined to the GI system, then you won't get symptoms of carcinoid syndrome. If the tumor is metastatic to the liver or beyond, then the tumor can't break down the serotonin, and you will get symptoms of serotonin syndrome. If the tumor is metastasized to the liver or beyond, then the liver can't break down the serotonin, and you get symptoms of carcinoid syndrome. Now we're essentially done discussing the bowel, and we'll spend some time learning about the liver before finishing with pancreatic pathology. First, we have this great diagram showing all the sequelae of cirrhosis. Portal hypertension is a more broad category, of which cirrhosis is one possible cause. Cirrho is the Greek term for tawny yellow, which describes the color of jaundice. Cirrhosis is the technical term for diffuse fibrosis of the liver, where the normal architecture has been destroyed. There's some amount of nodular regeneration, and cirrhosis has been described by some as being either micronodular or macronodular, which may have some prognostic significance. Micronodular cirrhosis is due to metabolic insults, including alcohol, hemochromatosis, and Wilson's disease. Macronodular is from significant liver injuries such as post-infectious or drug-induced hepatitis. The macronodular forms demonstrate a higher risk of hepatocellular carcinoma. As we've discussed in detail before, portal hypertension can be relieved by a variety of different portosystemic anastomoses. Now let's take a look at the effects of cirrhosis on the rest of the body. There are a lot, and they're all related to the failure of the liver to carry out its intended functions. As you can tell, the liver is a critical organ with many functions, and destroying it through cirrhosis is devastating. The first thing we want to mention is jaundice, which is how cirrhosis got its name. The buildup of bilirubin in the blood, which we also discussed earlier, gives the skin a tawny yellow color, which can be observed in its earliest stages in the eyes before changing the skin's color. This is referred to as scleral icterus. Other skin manifestations include spider nevi and caput medusae. Now we'll just go head to toe for other effects. Decompensated cirrhosis can put patients into a coma. Scleral icterus is the technical term for jaundice of the eyes, as we mentioned before. Fetor hepaticus is a foul smell to the breath that may be apparent in late stages. Gynecomastia and testicular atrophy, as well as ankle edema, are other symptoms. A physical exam finding you may elicit is called asterixis, or the liver flap. You normally test for this by having patients hold their hands out and see if they can keep them steady. Lab findings would include anemia and bleeding tendencies, specifically a decrease in prothrombin time and clotting factors. Lastly, we'll mention the effects of portal hypertension, which you're already familiar with. The mnemonic we used before was gut, butt, and caput, or caput medusae, and it still applies. You can have esophageal varices, hemorrhoids, and caput medusae. Additionally, patients develop peptic ulcers, splenomegaly, ascites, and gastropathy. Truly, there are many painful consequences to cirrhosis.